George. I'm an orthopedic surgeon. I'm at Aintree in Liverpool. I'm also a clinical teacher in the School of Medicine. I work for and I also voluntarily also for the British Society of Lifestyle Medicine and also College of Medicine. What we're going today is we're going to look at the anatomy, some biomechanics, some various conditions affecting the foot and ankle, and mainly focusing on non-surgical treatment and trying to emphasize the harm that may come from surgical treatment. That is what we're going to focus on. So when we assess the lower leg or the ankle, we want to know what was the past history, whether there was an injury there, when did it hurt, what was the quality of the pain and the duration of the pain, whether how were they feeling, how long they were disabled, whether there was any swelling or whether there was any previous treatment. But in a quick examination, you want to see, look, feel, and move. That is inspection, whether there is any swelling, whether there is any bleeding into the tissues, ecchymosis, or whether there is any deformity. And then you want to feel the medial and the lateral malleolus. I'll show what is the medial and lateral malleolus later on. Base of the fifth metatarsal, the Achilles tendon, the mid part of the foot, and even the proximal fibula. And we'll go through different cases why these are all important. And you want to see the range of motion. There is dorsiflexion and plantar flexion, eversion and inversion, the strength. We want to assess the neurovascular status and any special tests. So this is the bony structure of the foot seen from the, in an AP view or the top down. So those are the phalanges where the toes are. That is a metatarsophalangeal joint. These are the metatarsals. Then you have the tarsal bones, which are the cuneiforms, the cuboid, the navicular, talus, and calcaneum. And if you look at it from the side, you have the tibia, the talus, the calcaneum, navicular, cuneiform, metatarsal, and the phalanges. I've only shown the lateral side, but there are three main ligaments here. So this is the outer side of the ankle. The outer side, you can see the fibula. There are three main ligaments. There's one from the fibula to the talus. So this is the anterior talofibular. I've said that that's the first because that is the ligament that is usually damaged in an ankle sprain. If the ankle sprain becomes, that is when you're inverting the ankle, that is the commonest ankle injury that you get. Sometimes it may continue more and you break there and then you start breaking the second ligament also, which is the calcaneofibular ligament. If one or only two is broken, quite likely it heals well without any surgical intervention. Only when you have chronic instability surgery may be required. The third in the line is the posterior talofibular ligament. So they go in sequence, and that is how a ligamentous injury, and usually most of the ligamentous injury are on the outer aspect of the ankle. The way the foot is, because we are biped, that is, we have only two legs, unlike many other quadrupeds which have four legs. But because we have biped, we need to balance in our foot, and there are multiple arches. There is from front to back, there is the arch, the outer side, the lateral longitudinal arch, the inner side, the medial longitudinal arch. In addition, there's also a transverse arch which goes across the foot. So there is one in the heads of the metatarsal, and the same continuation comes over the tarsal bones also. These arches allow the cushioning of the foot, and we'll come to why the cushioning of the foot is important. Sometimes we may have high arch or cavus foot, or sometimes we have a planus foot, plano-valgus foot, where there is a flat foot deformity. Itself separately, if you have a flat foot or a high arch, it may not hurt you, but sometimes it can cause pain, and we'll come to that. But even a normal foot can cause pain, and we'll address that in a minute. Now, there are two movements in the ankle. One is called dorsiflexion and plantar flexion. So the foot coming up is dorsiflexion, going down is plantar flexion. That occurs in this joint here, which is the ankle joint. So that goes foot up and down, occurs in the ankle joint. Whereas a side-to-side motion, which is the inversion and eversion, doesn't occur at the ankle joint, does not occur here, but occurs the joint here, the subtalar joint. So side to side motion is in the subtalar joint. But when we are examining a patient, it is also important to examine the footwear, because the footwear may tell us a story. See whether in this footwear you can see they're putting more where it is wearing out more on the back side of the, sole of the footwear. So the footwear is important, and also whether they are using any walking aids. That also forms part of the examination and gives us clues on what could be the potential diagnosis. Now there are rules when you have an ankle sprain, whether there is a fracture or not. So there is the Ottawa rule. So they identified to reduce the risk of, X-rays are also bad. Too many X-rays are bad. So to decrease the amount of X-rays, they have come up with the Ottawa rules. So you only take an X-ray if the back of the lateral malleolus or the back of the posterior malleolus is tender, or there is tenderness in the navicular or in the fifth metatarsal. If there is no tenderness in these areas, it is usually very tender in the front because that is where a sprain is. So that is not important. It's only the back of the lateral malleolus and the back of the medial malleolus that is important. By doing that, they are able to decrease the number of X-rays being taken. And it has got a 98% sensitivity. That is, they are quite likely to pick up a fracture. So most of the sprains don't require X-ray. They just need a boot, one of the ski boots or a moon boot, whatever we call it, and then walking on it, and that will heal up so we look at a few conditions. So the first condition I want to look at is plantar fasciitis. Now, this is the plantar fascia. It is at the bottom of the foot, attached on the calcaneum, towards a distal part. Now, it is called plantar fasciitis, but we need to consider whether actually there is an inflammation. It is not really an inflammation. It is a chronic degenerative process. So it is ideally the name should be plantar fasciosis, but we are not going to immerse ourselves in semantics. We are going to come to what exactly happens. Now, patients who have plantar fasciitis, they complain of pain basically near the heel of the foot, and the pain is worst, at that area, the medial plantar region. That is where they say is the worst pain. And the worst pain is when they wake up early in the morning. They are not able to, the first step, as they get out of the bed, the first step is very painful. And in plantar fasciitis. So that comes to that's how you can diagnose plantar fasciitis. Yes, we can take MRI scans and may show an inflammation there, or you can take a CT scan which may show a spur, but these are all not necessary. It is easily a clinical diagnosis, but I'm just giving you for explanation. Or you can do an ultrasound and you can see there is thickening of the fascia there. But majority is a clinical decision and diagnosis. But why does it happen? We have to understand it is the rocker. There are three rockers in the heel and the ankle. What are the three rockers? If we had wheels under, there wouldn't be a need for rockers. But we don't have wheels under our feet, or our feet are not made of wheels. They are just feet. And because they are feet, it doesn't move like a circle, it moves like a hexagon. So obviously, it has to go through different stages. So those stages are called the rockers. So the first stage that happens is the heel strikes, and when the heel strikes, the foot comes to the floor, and that is the first rocker. This is the first 1/3 of the wheel going down. Then you have the second rocker. The second rocker is when the tibia goes over the talus. So that is a second rocker. Then you have the third rocker, and the third rocker is when the foot rises over the metatarsophalangeal joint there. So that is the third rocker. Together, these three motions allow us to go like a wheel on the surface. But it is the third rocker that causes the stretch on the plantar fascia, and there is repeated, stretching where it is attached to the calcaneum, and that is where it may hurt. So that is how plantar fasciitis occurs, and majority of the pain, as I said, is on the heel. Now, this is where the main pain is, at the tip of the bottom of the heel. Now, yes, we could. There are some people who do injections, but I don't like injections at all. Injections, one, it can be very painful procedure. And most importantly, the injection, we are giving steroid. Yes, it may be a quick fix, but in some patients, the steroid can actually cause atrophy. We are all able to walk because underneath our heel, there is a nice thick cushion. So lots of fat, condensed fascia acts as a cushion. So we are walking on a thick cushion. Unfortunately, if you give steroid, that cushion can atrophy, which means there won't be a fat pad there, and we'll be directly walking on bone, and that is very, very painful. And once that happens, there is not even an operation that can be done to rectify it. Yes, I know a lot of injections are being done, but plantar fasciitis will heal well without anything being done. It is a disease that will come, it is completely a finite disease. In 2 years, it'll get better naturally. So what you want is pain relief within those 2 years, and that can be easily done by exercises and analgesics, and if need be, orthotics. And I'll explain to that. But before we go to exercises, I just want you to understand two different types of exercise or in motion. One is a concentric, the other one is an eccentric. Now you can see this gentleman taking a dumbbell and bending his elbow. When he is lifting the dumbbell up, that time the biceps is contracting. So this contraction is called the concentric contraction. Whereas when if the dumbbell was here and he's slowly lowering it down, the biceps is extending, but still it is acting. It is not suddenly dropping down on the floor. It is slowly being released down. So that contraction now of the biceps is an eccentric contraction. So many of the tendinopathies, what the type of exercise we need is eccentric exercises or eccentric stretching, just like how the biceps is being stretched here. So there are 3 or 4 exercises for plantar fascia. It's one of the first exercise is a direct plantar fascia stretch. So if the right foot is a problem, hold the toe with the right hand, pull the toe up and the foot in dorsiflexion and try to massage the plantar fascia. See how the stretches and hold it for a count of 10 and repeat it 3 times. That is one form of stretching the plantar fascia. The second way of stretching the plantar fascia is a wall stretch. So one stands in front of a wall about a feet or feet, about 18 inches away from the wall. Put your hand flat, so the hands will be flat on the wall, and then try to get the chest closer to the wall. So you're bending your elbow and getting your chest closer to the wall. At that point, also the feet are completely flat on the floor. Then slowly try to get the hips to the floor and maintain the heels on the floor. While you're getting the hips to the wall and keeping the heel on the floor, this posterior muscles are being stretched and the plantar fascia are also being stretched. So one is when you have plantar fascia, there is some contraction in the gastrocnemius muscle. So those muscles need stretching as well as the plantar fascia, and you can feel the stretch at the back of the heel and also on the undersurface of the foot. And you again hold it for a count of 10 and repeat it 3 times. The third exercise is a step stretch. So you'll need a banister and you should stand on the most bottom step. Only keep the front of the foot on the step. The heel should be free. And while holding on the banister, allow the heel to go down, depress the heel down, and that will also stretch the plantar fascia. Again, hold it for a count of 10 and then return to normal. Repeat 3 times. The fourth one is a can stretch. You can take any soft can, keep it in the floor, and gently roll, up and down 10 times or for a minute, and then you can repeat it 3 times. So that is a can stretch. All these, if done, will reduce plantar fasciitis and the symptoms. But if it is still painful, instead of surgery, instead of injection, it is a orthotic that we need. The orthotic cradles the foot and supports the plantar fascia. So it has to be a good orthotic which has a good arch support. And by doing that, the inflammation or the degeneration in the plantar fascia attachment is decreased. So we actually did some study, and this was published a few years ago. So we used, for patients, we gave this orthotic, and we also gave them a footwear to wear, because the orthotic can only be put in a shoe. But early in the morning when they wake up, they don't have a shoe, so they can't put the foot into a shoe. So we need to give them some footwear, sandals, which has an arch support. So we gave them an orthotic sandal with an arch support and an orthotic to put into the shoe. So as soon as they wake up, they put into the sandals and walk, and they were experiencing less pain. And we found that the study showed that the group that had this had much better statistically significant improvement. The next condition I want to talk about is metatarsalgia. So from one end of the foot, now we come to the other end of the foot. So plantar fasciitis was here, but metatarsalgia is the head of the metatarsals. Now that could be sometimes related to geometry of the foot, and we'll look at that in a minute. So there are three types of metatarsalgia: primary metatarsalgia from direct loading, a secondary metatarsalgia from indirect loading, and an iatrogenic metatarsalgia. Iatrogenic means caused because of surgery or because of medical intervention. So let me explain this. So this is the way there are different feet are. This is what is known as the Egyptian foot. This is known as the Greek foot, and this is known as the Roman foot. This is based on the statues that you find in Egypt, Greece, and Rome. So in Egypt, when the first this metatarsal, the great toe, is longer, there is no primary metatarsalgia. Why? Because this is longer. This will land on the ground before the other metatarsals are landing on the ground. The first metatarsal is for the of the great toe is stout, big, and it can take that weight to the body. So if that lands first, then there is no issue. But in the Greek type of foot, that's only the Greek is meant on the statues in Greece. The first metatarsal is short, but because it is short and not long, the second metatarsal lands on the ground first. When the second metatarsal lands on it is taking a lot of weight. It is not as big as the first metatarsal. So when the second metatarsal lands on the foot, there is greater pressure underneath the head of the metatarsal, and that is why we may get this primary metatarsalgia because of the construction, the way the geometry of the foot is. There's also the Roman foot, but that doesn't, you don't get where the first metatarsal is same level as the second metatarsal. You don't get foot pain there, metatarsalgia there. So the primary metatarsalgia is when we have this the lack of geometry mainly occurs in the Greek toe, not in the Egyptian or the Roman toe. So this is the X-ray, and you can see the first metatarsal is short, the second metatarsal is long, and because the second metatarsal is long, as the person is walking, this head of the second metatarsal is going to land on the ground first, and when it lands on the ground, that it's taking more weight than what it is normally meant to take, and that is why they get callosity underneath the foot. So again, this photograph of a first primary metatarsalgia, and I do not know, on this foot you can't see very clearly, but on this foot you can see the callosity underneath the second and the third metatarsal. Not see, so there is not much of weight bearing here. Majority of the weight bearing is here. So this is primary metatarsalgia. Then there is, again, this is another callosity in the underneath second. Sometimes the foot, because the second metatarsal is so long, you may even get a stress fracture in the second metatarsal, because that is taking a lot of hammering compared to the first metatarsal, which is actually meant to do the job, but now the second is doing the job. What is secondary metatarsalgia? It's not basically because of the first metatarsal is long. Here there is a primary, some other primary disease like rheumatoid arthritis or diabetes, or usually rheumatoid arthritis or one of the autoimmune arthritis. And because of that, there is a pad underneath, the plantar pad underneath the metatarsal heads. Because of the deformities and the joint is damaged, the fat pad shifts away, and when the fat pad shifts away, these metatarsal heads directly contact. So there's only the skin underneath them, and contacts the floor, and there can be severe pain. And that is secondary metatarsalgia. You can see significant deformities, but now with newer medications, we are seeing less deformities in these people with autoimmune arthritis. But there is a new type of metatarsalgia that is coming very increasingly, and that's called iatrogenic metatarsalgia. Iatrogenic caused because of the operation. So this patient had hallux valgus or bunions. The operation was meant to shorten the or decrease the angle of the bunion. But when they decrease, they also decrease the angle, they also decrease the length. And because they decrease the length, now the other metatarsals became relatively longer. And underneath the second and the third metatarsal, there was more weight bearing. And you can see how the callosity has developed underneath the second and the third metatarsal as compared to the first metatarsal. That only happened after surgery. Yes, she may have, I mean, I don't think this feet look much better than before, but yes, she had an operation and now she's got a new pain compared to the other pain that she had before. So this is called transfer metatarsalgia. When your surgery for hallux valgus, you reduce the length of the you're trying to correct the angle, but unfortunately you may also reduce the length, and then the other metatarsals contact the flow, and we have increased pain. But if that happens, one of the easiest methods to solve is give a orthotic with a metatarsal pad. A metatarsal pad is a small bulge underneath the orthotic which can lift the metatarsals. And what happens then, this sort of small bulge of the metatarsal pad will shift the weight and equalize the weight along those metatarsals. And so this pointed ends of the second and third metatarsal are not hitting on the floor, and you can find relief with that. So 92% of these are biomechanical. Stretching and orthotics with metatarsal pad and forefoot cushioning should solve the problem. But there is one metatarsalgia called Morton's metatarsalgia. This only usually occurs between the third and the fourth metatarsal. These yellow lines that I've shown are the nerves, the digital nerves that go to the toes. The digital nerves come between the metatarsal heads, then separate out and go to either side of the toe. But unfortunately, this nerve somehow between the third and the fourth gets trapped between the head of the third and the head of the fourth metatarsal. And the repeated impact of the heads of the metatarsal on the nerve causes swelling of the nerve, inflammation, and it forms, because it is swelling, it gets cramped further, and there is numbness along this area. And when the patient is walking, as this part of the foot touches the floor, they have severe pain. So you will also find a sort of a pseudo tumor, and it most commonly occurs between the third and the fourth metatarsal, and there is chronic irritation there. So walking makes it very difficult. Walking becomes very difficult. And the sign there is a positive Mulder's sign. So if you take the whole foot, hold it with your hand and squeeze it, you're actually taking out that small tumor from the center of between the third and the fourth metatarsal. It'll dislodge upwards, and then you can push it back in. And while you push the small tumor or the nodule of the nerve, you can hear a small clicking noise, and that clicking noise is the Mulder's click or the Mulder's sign. And that is characteristic of the Morton's neuroma. Again, if there is a Morton's neuroma, a metatarsal pad, what happens is when we put a metatarsal pad, it widens out and separates out the metatarsal heads, and there is more space and thus less crushing of the metatarsal heads together. Some of all these conditions are caused because of our footwear. We like to wear narrow footwear, small footwear, and that is where majority of these issues arise. The third condition I want to discuss is hallux valgus or bunion. That is where the great toe starts pointing outwards. Now, this is the bunion, or what we call as the hallux valgus. Hallux valgus is for the great toe, and the bunion is the deformity that we see here. But why do we get this deformity? Yes, there are many reasons. But it's because of the first ray, that is the part of the metatarsal and the phalanges connected to the first ray. Why? Because they separate out like this, and when they separate out, we develop an increased division here called the intermetatarsal angle, and then you have a hallux valgus angle. But the important thing why this happens is we have to look at evolution. We were apes, And when we were apes, we were on the trees. And when we were on the trees, our legs or feet were like this. It had to hold on to the trunks to jump from one tree to another. So that evolutionary weakness is still there. We are not no more climbing trees like apes, but because of that evolutionary, the way we have evolved, that weakness is there, and that is why so it is not the great toe moving outwards that occurs first. It is this part, the first metatarsal pointing inwards is the first step. The secondary step is the great toe pointing outwards. And yes, all these conditions can actually increase the chance of the hallux valgus, narrow shoes, because they say narrow shoes make you look prettier. Short shoes make you look prettier. So people want to wear short and narrow shoes. High heels, they say makes you look prettier. And again, there is an increased stress on the metatarsal heads. Flat shoes, it needs to have some arch and sometimes flat feet. And there are genetics also involved, and that may cause the hallux valgus or the bunion. So this is hallux valgus. It's been operated on the right, but not much of correction has occurred. And again, if it is not too bad, just putting an orthotic with a metatarsal pad may be giving. But most important thing is prevention, wearing a roomier shoe which will accommodate your foot. Putting narrow shoes and getting the toes together is going to increase the chance of hallux valgus. Next is diabetes. That is a major problem. Now, we are talking mainly of type 2 diabetes. Type 2 diabetes is associated with insulin resistance. And unfortunately, the vessels, the small vessels to the feet and to the hands are affected. When the small vessels are affected, the nerves are also affected. And we get neuropathy, which means there is no sensation. And sometimes there may also, in addition, there may be pain in the foot. So the foot will develop ulcers, and the ulcer is the beginning of the problem. So we need to try to avoid that. Good diabetic control or even reversal of the diabetes can help us prevent this. Now, when I talk of diabetes, I always want to talk a little bit about leprosy, because leprosy is quite similar. The neuropathy that you get in leprosy is quite similar to what you get in diabetes. Now, I'll give you a small riddle and I want you to solve this riddle. Any one of you can tell me the answer to this if you don't, or if you know the answer. So, the father of tendon surgery is someone called Paul Brand. And this is more than 100 years ago, 1920s. He came, his parents were missionaries in India. It's from Tamil Nadu. I'm from Coimbatore here, and this is where my parents used to live. I'm from, traditionally, I'm from Trivandrum and Kerala, but this is where I grew up. And there is a place here called Kollimalai. And that's in the wild, in the forest. Now there are roads, and you can see how the windy roads are. But this missionary was there more than 100 missionary, and Paul Brand was his son. So Paul Brand. So there was a lot of leprosy in that area. And unfortunately, the problem in leprosy was the hands and the toes would get numb. And unfortunately, people were losing the tips of the toes and tips of the hands. And the local folk thought it was the gods who were angry with them. That is why they would go to sleep and the toes and the hands were dropping off. Paul Brand was a scientist. He was a doctor. He said that I can't accept that. So he kept awake at night and watched people when they were sleeping. And then he realized that, I mean, this is 100 years ago. There is no electricity, no light. So he had to light a fire and keep it, lit the whole night to see what was happening. Then he realized actually, when people were sleeping, the rats would come and eat away the tips of the toes and the fingers. And that is how, when they wake up in the morning, and the important thing is rats don't eat live animals at all. It will only eat dead animals. So then how were the rats eating? Because when the rat eats, the first thing they do is they blow on the object. If you have some sensation, you will move away. And if you move away, the rat will not bite you. But because these people didn't have sensation, their toes and hands remain in the same place, and the rats would gnaw on them, and the next day morning they'll wake up without toes or without fingers. They blamed it on the gods, but then Paul Brand realized it was not the gods. So then he made some shoes. So that's the book that he wrote, The Shoes That Love Made. But within 6 weeks, he stopped the rats eating the patient's toes and fingers. And I want one of you to tell me how we manage that. You can either put it on the chat, or we can discuss it later on when we finish this thing. So it's something for you. He managed it 100 years ago. It is not dressing, it was not lights or anything. It was a remote area where there was less technology, but he managed it. And you need to tell me how he did it. And this happens with diabetes. You can have callus formation, you can have deformity, you can have an active ulcer. And once this happens, then it is a slow progression, and it's very difficult to, control it. Yes, it is important in diabetics that we need to see the pulses. So you have two pulses in the foot. One is in the front, the dorsalis pedis. The other one is the back, the posterior tibial. And we also need this test sensation. This is the instrument used to test sensation. So it is like a plastic fiber which will bend. It's called the 10-gram bend. So we should be able to feel the sensation. So it is a small fiber, and you push it against the toe, and when it bends, that is the adequate pressure that is being applied. And one should be able to recognize it. If one can't recognize the 10-gram Weinstein monofilament, then there is numbness or diabetic neuropathy. But you don't need this instrument. Even simple touching with the hands is good enough. So it is important that someone who is diabetic has a mirror on the floor, and they are observing the underpart, the sole of the foot regularly, and some friend of theirs are touching the toes once in a week or something to see whether there is normal sensation. Because if you catch it early, you can prevent. Because the problem is, if the infection or the ulcer becomes worse, then you get what is known as a Charcot foot. You can see this is the X-ray of the Charcot foot. The joint is completely destroyed because there is no more sensation. Small damages keep on occurring, and there is the entire shape of the foot changes. It becomes a boat-shaped foot, and that is the Charcot's atrophy. And you can see how this patient has a boat-shaped foot with infection. This is going to land in an amputation. You can see on the MRI scan, destruction of the bone. The talus is more vertical. Some of the bone has been eaten away by this infection. Now we are having a lot of amputations. In the UK itself, we have 135 amputations are occurring per week. Totally 137 legs are going off. And what we know is majority of them are preventable. That is, if they follow right advice, if they follow diabetic control, if they reduce their weight, you know, then these amputations are not going to occur. But unfortunately, what we have seen is statistics show that 135 amputations, and this is preventable. And we need to see that this can be changed. And that is why College of Medicine and such organizations are working to reduce this. Now, unfortunately, even though this is such a big problem, diabetes is on sale. Right as a child, we are addicted to sugar. We look at sugar and we want to start consuming sugar. So, and there should be a restriction, because you make it so attractive for a child, the child is going to take these sweets, and once addicted at a younger age, they continue the addiction later on. A little bit on falls and frailty is important. One, it can cause injury to the foot, but also the origin of the falls and frailty may be in the foot. So as we grow older, we lose balance and we may fall, and that may cause problems. That is also possible because of the pain in the foot may indirectly cause us to have falls. But it is important to notice that we may have proprioception. So let me explain a little bit on that. We need balance. Now, balance comes from three different parts. One, we have our ears, and we have our semicircular canals. This is the cochlea, which allows us to hear, but there are three tubes in the inside of the ear which has fluid in them, and the inside of the tubes have minor micro hairs. So as you turn your head, the fluid moves within those tubes and it will move the hairs, and by moving the hairs and the fluid, then we know which way our head is turning. So suddenly if you're falling, those what the fluid in the tubes moves around, the hairs move in a particular way, and that's how we know we are going to one side or the other side. So balance comes from the ears. Balance also comes from the eye. The eye see what's happening around, so it gives a feedback whether we are falling or not falling. But more importantly, we have proprioception. Our feet carry sensation to the brain. So if the feet are well supported, then we can carry better sensation to the brain, and we will be able to, there is less likelihood of falls. So in this lady who had falls problem, and she's also got an ankle fracture, you can see she's got an operation following an ankle fracture. She had difficulty weight bearing, and she had increased amount of falls. And you can see how she's walking not very comfortably, not much of change when the walking. And we gave her an orthotic. And following the orthotic, she is walking much better. And how did the orthotic help to prevent falls or improve the balance? What happens is when you're not walking with an orthotic, the amount of feedback is very limited. Your foot, only the front of the foot and the heel and the outer aspect of the foot is in contact with the floor. Whereas when we have an orthotic and which is cushioned and touches the whole amount of the foot, then there is a wider surface area contacting the sole of the foot, and there is more sensations going up to the brain. So that is why we have better balance and better control and less falls. And surprisingly, we did some research and we found that if you add a metatarsal bar, it's like, the blind person uses a stick and feels the ground. That metatarsal bar acts as an increased support or gives further feedback to the person, and they are able to, decrease their falls. So this is what we did. We had one group of patients who had orthotics with metatarsal pad, other without metatarsal pad. Both there was decrease in foot pain with the metatarsal pad. There was a greater for a decrease of foot pain as compared to without the metatarsal pad. And also what we found is their fear of falling, this is FES, fear of falling, was much decreased in the ones that had the pad with compared to without the pad. And we published that results in an article. A little about sports injuries and stress fractures. Now, majority of the issues in the feet when we are running or doing sports occur from the knee. We may have shin splints, you have stress fracture or stress fracture of the metatarsals. Now, why that may happen as we run is because of the movement, because of the pronation that may occur. So as we land, and there is a difference between short running and non-short running. Short running is when we run with our shoes on. Yes, if our ground was good, there was soft ground and there was no glass pieces or rocks to harm, yes, running barefoot would be good. But in this current world, we cannot run barefoot, so we have to wear shoes. But as soon as we run with shoes, we land on the heel. When we land on the heel, and then what happens, the center of gravity is slightly inside the foot then rotates inwards. There is a pronation in the foot. As the foot rotates inwards, it also takes the tibia inwards, so there is a rotation of the tibia. When the tibia rotates, it's like a domino effect, goes more proximally, then the femur rotates inwards. To prevent the foot, the tibia, and the femur rotating inwards, the quadriceps or the thigh muscle in the front acts and pulls the kneecap the other way, and that is where there is a mismatch. And that is where you have most of the running related problems coming with knee pain. So because of this mismatch, the others are turning and the balancing is being done by the kneecap. But as when you have orthotics, what happens is without orthotics, there is a pronation. But as you have orthotics, I'm very biased in favor of orthotics. I think they need, orthotics are very beneficial. And these are the other injuries. You can have posterior medial shin splints, anterior shin splints. A little about stress fractures. What is a stress fracture? A normal fracture is something like this. You take 100 kilograms, drop it on bone, it will break. That is a normal fracture. But on the other hand, if you have repeated minimal stress, small hammer, 1 kilogram hammer, repeatedly doing, yes, you're not breaking the whole bone, but you're breaking some fibers of the bone. As you break some fibers, the bone is trying to heal that broken bit. But the amount of healing is not able to compensate the amount of damage done, because the stress fracture occurs in someone who's running very frequently or running more than what is used to. And happens, I see a lot of women coming with stress fractures. They all want to look young, thin, want to exercise a lot, and they run and they come to the clinic with stress fractures in their hips, sometimes in the hip, sometimes in the ankle or the feet. So it is important that you're only doing what you can, and they eat less also. There is this, unfortunately, there is this thing that you need to look like a Barbie. It's not necessary. Everyone is beautiful. No one needs to look like Barbie. This a person who's had a stress fracture in the calcaneum, you can see, and obviously they had to stop running. Coming to acute injuries, sprains, ankle sprain, as we said, the most commonest injury is the anterior talar fibula, and the next is calcaneal fibula, and sometimes the posterior talar fibula. But you can also have a high ankle sprain where the syndesmotic ligaments are damaged, and we'll look at that in a minute. So this is where foot turns inwards and you have a lateral inversion sprain. That is where the anterior talofibular ligament is damaged. Or you can have a medial eversion sprain and where the medial deltoid ligaments. But this is less common. The other one is more common. The test to do is the anterior drawer test. So you hold the foot by the heel and try to pull it forward, not in an acute setting, in a chronic setting. In an acute setting, you allow it to settle and it'll heal up quite well. In a chronic, if there is instability, that is how you test it to see whether there is any instability. Now, sometimes you can also tilt the talus. You hold the whole of the ankle and tilt it, and it will find that this part increases further. If need be, we can also take an X-ray and see that the talus is tilted. You can grade the amount of sprain as whether it is grade 1, grade 2, or a complete rupture, and depending on this. But most of this can be healed can be treated without surgical intervention. And the important thing is neuromuscular ankle training, increasing the strength, improved proprioception, balance exercises like the wobble board, rolling a football while you're seated underneath the foot, all that increases the proprioception. And initially, you just need an air splint or a boot and crutches if there is pain, and rise, that is rest, ice, compression, and elevation, and slowly emphasize on early mobilization exercises, and they will heal very well. As I said, sometimes there will be the high ankle sprain. So this is the low ankle sprain when the anterior talofibular and the lateral calcaneofibular. But sometimes the anterior inferior tibiofibular and the posterior inferior tibiofibular ligament may be damaged. Then it is a high ankle sprain. There will be more pain, and then what happens is when you squeeze the leg, not the foot, there is increased pain because that is where the ligaments are broken. They may need not just normal mobilization, may need a full ski boot for a few periods. It may take more time to heal up than the normal ankle sprain. But again, it can heal up without surgical intervention. Only very rarely surgical intervention is necessary. But this may take up to 2 times the time to recover compared to a normal ankle sprain. But very important, sometimes that same sprain may become, and you may have a fracture, a Mason fracture, which is a fracture very high up in the fibula, and that should not be missed. Now, coming to orthotics and stress, we did a study on orthotics when running, and we found that if you use orthotics while you run, it is more comfortable and there is less injuries. So this is one of the scores we found, that people who ran with orthotics, their comfort level was higher than if they didn't wear an orthotic. The speed was slightly, but that was not statistically significant. But there was a significant difference. There were more injuries if you ran without an orthotic as compared to with an orthotic. So it is protected. And this is the article that we published. But we must, I am very much in favor of orthotics, and this is why 25% of the population have ankle and foot and ankle pain. and their walking becomes difficult for them. But if we need to make them walk, we need to make them active. And easy ways, as I said earlier, we were apes, we were on trees, and then we came to the ground. But when we came to the ground, we were on soft ground, ground which is grass or sand. And the foot would, walk very well on grass. Like when you go on a holiday and when you're walking on the sand, you're creating impression. Now you must understand that is Mother Earth cradling your every step. So there is over a wide area you're taking the weight bearing. But that is not what happens naturally, because what we have done, as soon as we invented the wheel, we made all surfaces hard surfaces because we need the wheels to go around. But the hard surfaces is not good for our feet because they were not meant to go on hard surfaces. If we were meant to go on hard surfaces, nature would have given us hooves, not feet. And whereas we have given feet and now we are going. This is a simple experiment. This is my daughter's feet. So what I did is I put a piece of paper, put green paint on her foot, and put a paper on the tarmac and asked her to step over it. And I put the same paper on grass and asked her to stamp over it. When she's on grass, you can see there's a much wider area of contact, whereas on the tarmac there's a much lesser area. And we know the pressure is area by the force by area. So obviously if it is a larger area, the pressure is much less. So that is why an orthotic, taking the weight bearing, and that gives you the natural conditions like how we would walk on grass or on sand. A few other conditions: we may have arthritis in the ankle joint from following trauma, subtalar joint, midfoot, and also in the metatarsophalangeal joint. The another condition is the acquired flat foot. As we become older, this is the posterior tibial tendon that becomes weak. That helps us to keep the arch up, pull the arch, and maintain a straight foot. So older people, sometimes unfortunately more women, they have the weakness of the posterior tibial tendon, and they may lose and their arches may collapse. So this is when your excessive pronation occurs. This is the normal position and there is excessive pronation. You can see on this, looking at from the back, you can see the pronation on both sides. The way to identify the test is too many toes sign. When you look at a patient from the back, you should only be seeing 1.5 toes. But on this side, you can see 3 toes, and on this side, you can nearly see about 4 or 4.5 toes. So if more ideally, you should only see 1.5 toes. So this is called the too many toes sign, and that shows there is flat feet. Again, doesn't need surgery, just a supportive footwear is required. You can see again there is too many toes. But the good thing about acquired flat foot is when they tiptoe, that same the collapsed arch completely disappears because you're now pulling up the foot and the arches are restored. The flat foot goes and the arches are restored. See this person walking. As he walks, you can see he's collapsing slightly more on the left than on the right. He's also got a little bit of valgus on his left, and that is why he's collapsing more on the left. And they can do quite well with just an arch support and supporting. Yeah. So you can see how his feet are collapsing on the inside. Then there are deformities in the toes. You have hammer toe, claw toes. So the hammer toe is if there is a flexion deformity at the proximal interphalangeal joint. Claw toe is there is deformity both at the proximal and at the distal interphalangeal joint, and mallet toes is a deformity at the distal tip. Again, some yes, genetic, partly autoimmune diseases, but also partly the footwear that we wear. The closed, tight footwear can cause these deformities. Look at the hammer toes that we see, claw toes that we see here. Yes, sometimes surgery can be done, but it's painful. The most important thing is avoidance and preventing this from reaching there. Hallux rigidus is where there is arthritis in the first metatarsophalangeal joint. Can happen with gout when there is arthritis, or otherwise can happen when there is, as you said, the shortened first metatarsal. You can have sesamoiditis. What is sesamoiditis? For the great toe, we have two tendons, a flexor hallucis longus. There is a small bone within the tendon. A sesamoid bone is a bone which is inside the tendon. Now, our kneecap is a sesamoid bone. That is the biggest sesamoid bone in the body. Why, if I explain to you why we have a kneecap, then I'll come back to the foot. The thigh muscle or the quadriceps is one of the strongest anti-gravity muscles. When we are sat down and when we have to lift our bodies up, that quadriceps muscles work. Now, even the gluteals is an anti-gravity muscle. You're squatting, you lift up, your gluteus and your quadriceps are working. The advantage of the gluteus, it is short and stout and it has got a lot of strength. Whereas the quadriceps is a long muscle, it doesn't have a lot of advantage and that is becomes to fail. So the patella or the kneecap is given by nature to act like a pulley system, and that is how we are able to, work against gravity. Now, same way, we needed the great toe a lot because, as I said, we were apes and we were on the trees. The great toe had to hold on to the trees as we were climbing. So it needed a lot of strength, and that is why nature gave us these sesamoid bones. But we don't need it, but evolutionally we have received it. And unfortunately, sometimes there can be sesamoiditis, small fractures, or inflammation in the bone, and that can cause pain and difficulty. The worst thing is to get a CRPS. CRPS is complex regional pain syndrome. And sometimes we don't know why that happens. The next seminar is on looking at CRPS or chronic pain. So here this gentleman had just a small fracture of the third metatarsal. He had an operation. I can see the CT scan. There was mild. It could have been left alone maybe. We could have treated non-operatively. But he underwent an operation. He's now got such severe pain in his foot that he can't put his foot on the floor at all. He walks with this contraption where he is kneeling on this and he is walking everywhere because he just cannot. His pain is real. I'm not, he's not making it. His pain is so real. Here is a fracture calcaneum. Falling from a height, you can damage the calcaneum. It's not clearly seen on this X-ray, but we can know it because the Bowler angle is changed. This is the Bowler angle. So there's an angle through the joint and the angle to the tuber. That should be 40 degrees, and that has decreased. This is the normal angle, 25 to 40 degrees. But if that decreases, then you know. And a CT scan will show us there is a fracture of the calcaneum. Again, can be treated non-operatively. We looked at gout where uric acid is increased, and that usually occurs in the first metatarsophalangeal joint. There's redness and swelling there. You can have high arched foot, a cavus foot, and we need to know whether that is deformity of the whole foot or only the first metatarsal coming down. Again, it may need appropriate orthotics. Achilles tendon rupture is again early morning when you're running for a bus. So if you train well, if you stretch well before an exercise, you're unlikely to get it. But if you don't train and suddenly run, then you will get an Achilles tendon rupture. Usually occurs when you're getting into the playground without actual warm-up. If you do an actual warm-up, stretch your tendons, you're unlikely to have injuries. So this is Achilles tendon is a direct. So if you just get, so usually happens is you're going to your train station, suddenly you see the train maybe departing, you run and you're in the cold, you have not stretched yourself, you get an Achilles tendon rupture. How to identify if there is an Achilles tendon rupture is sometimes it is missed. Now you see this on that foot there is no rupture. So when I'm squeezing the calf muscle, you can see the foot going pointing upwards. Whereas in the ruptured side, though I'm pressing the calf, there's hardly much movement in the foot at all. Whereas in the other side, there was a lot of movement. So on the right, so the left side, which is on this side, you can see that though I'm squeezing the calf, there is hardly any movement. But on the other side, where it is not damaged, as you squeeze, the foot goes, pushes down. You can see what I'm doing when I squeeze the calf there. You can see how the foot is moving. Easy test to identify whether the tendoachilles is damaged or not. Ankle fractures. So you can see this is a Weber B fracture over the syndesmosis. Only the lateral malleolus is affected. Treated with a boot, and we try to weight bear. As long as the malleolus is maintained, it will heal up quite well. And then after the plaster is taken off and we put into a boot, this is a boot, sorry, the first is a plaster, then we put into a boot, and again we take a weight bearing x-ray. If the mortise is maintained, allow it to heal, and this fracture heals up quite well. But some more complex fractures where there is disruption of the syndesmosis will require operative intervention. But the most, how to prevent, you have to stretch your tendons, stretch the surrounding muscles. Proprioceptive training is necessary. We all just cannot, everything needs proper training. We just can't into the football field and start kicking a ball, and you need proper footwear. I'll show you some of the disasters from surgery. This is a 45-year-old lady who had some midfoot arthritis. And unfortunately, on the right foot, she has got midfoot arthritis in both feet. She agreed for an operation, and one operation failed, second operation failed. In total, she had 18 operations, not one or two, 18, 18 operations. And you can see this is her state. So many screws into her foot, different parts have been fused. Some were taken off, some were put back in. And in the end, she is not walking. You'll think after 18 operations and so much of metal work, she would be walking very well. But that is not the case at all. You see how gingerly she is walking. She's not even able to keep her foot, properly on the floor. Uh, and you can see this is where the operation, majority of the operation is done from the outer aspect. So this is another patient, 65 years old. She had bilateral, you can see the hallux rigidus there, and she had fusion there and fusion of these interphalangeal joints. And again, she is in more pain now following the surgery than before the surgery. And she's got transfer metatarsalgia because this is, less and more pain on the outer aspects of the foot. And again, she walks very gingerly, cannot increase her pace of walking because of the foot. Yes, the foot may look a bit better. So yes, surgery is necessary at times, but we need to be as careful and avoid surgical intervention wherever possible. So looking back at all what we looked today, we looked at the anatomy, the bones, the tibia, the talus, and we looked at the arches. On the outer side, the usual ligamental sprain is the anterior talar fibula. The second is the calcaneal fibula ligament, and they will heal up very well. The ankle dorsiflexion and plantar flexion, foot up and down, occurs at the ankle joint. But the side to side motion, the inversion reversion, occurs at the subtalar joint. The stretches, like the wall stretch, is very good for plantar fasciitis, whereas it's the eccentric stretching as we looked at the dumbbell. And we looked at iatrogenic metatarsalgia, where we are trying to do a surgery for hallux valgus that unfortunately now causes pain underneath the lesser metatarsal heads. And again, we looked at hallux valgus, bunion, how narrow shoes, high heels, short, flat shoes can increase, but genetics is also involved. Diabetes is a big problem. We are creating Charcot's neuropathy with diabetes. And as I said, 135 amputations per week, and they are all, majority of them are avoidable. We need to decrease that. And the, post-op complications like this, where there is more pain in the foot. We looked at how there is overpronation on running, how the domino effect, the foot turning in, the lower leg turning in, the femur turning in, compensated by the patella turning out, can increase the pain in the knee in running. So a simple orthotic may help. 1/4 of the population have foot pain, but most of the others don't have. They don't need an orthotic, maybe. But if you're walking more distances, an orthotic will help. We looked at acquired flat foot where the posterior tibial tendon was weakened. And we looked at chronic regional pain syndrome, where just one surgery or one injury can cause severe pain, and that pain can be, very disabling. We looked at how to look at the tendo-Achilles rupture. When there is a when there is no rupture, it goes, fully. The foot moves very well when you squeeze a calf, but when there is a rupture, it doesn't. So this foot has a rupture, it doesn't move down.